Good morning. Again, if you are on the part of the planet that says good afternoon, good afternoon. If you're on that part of the planet that says good evening, good evening. We want to welcome you to another segment of Community Views and Solutions, and I'm Charles X. White, your host, brought to you by Charity Productions. Now, today, we're going to talk about and continue the conversation on mitigating risks, mitigating threats, whether it's physical, personal, or in the community. Those are three very near and dear categories that we all are concerned with in the area of physical, I guess you say mitigation. We are very sorely lacking in that area with neighborhoods that always flood, still flood, and continue to flood. Neighborhoods that continue to have a lot of fires, still have a lot of fires. So there's mitigation, and we are introducing for 2023 our mitigation and threat teams that we are developing with Charity Productions and the Community Partnership Exchange Breakfast. And for those of you who don't know, we are celebrating the 20th year of the Community Partnership Exchange Breakfast on October the 20th. And we're going to reach that milestone very shortly, and then we're getting ready for 2023. 2023 on Charity Productions' plate has to do with health and safety wellness. That's our focus, that's our theme for 2023. In that health and safety and wellness, that continues to be a area of deficiency, in particularly in African American communities. We want to address that. As you all remember, or may remember, we were right here with the Obamacare. We was tapped as a navigator to help navigate and try to get the public engaged in signing up for Obamacare 1 and 2. And you know, we've done these informational and outreach for the city of Houston when it came to COVID. So we always are trying to inform you and alert you to what steps and services that are available. Mark, if you'll go to that footprint slide, the one that has the reddish footprint first with the zip codes. Okay. Can you put it on the big screen, Mark, as well? Yes, sir, that's the right one. This is a map from the City of Houston Health Department. This map was created about 2010. And this map that they produced dealt with health disparities in particular zip codes in about 2010. Charity Productions came along in about 2017, and we laid a grid over their grid, and we looked at some conditions from existing health disparities, education, housing, and economic. And the new footprint, after we put those new stats over it, can you go to the next slide, Mark? The new footprint is what you see here. Can you put it on the big screen as well? That's the new footprint. And these disparities are healthcare related, education, economics, and some of them span at least 70 years as generational. So Charity Productions is looking at how do we change this paradigm? How do we align ourselves with agencies and providers that are informing the public on things they may not know or things that just aren't true? So we invited Absolute Hospice. Hospice is one of those areas of services that we really don't know a lot about. We hear a lot until it's the time that we need the service. And there are a lot of things that I'm finding out, and y'all know I had to deal with my mother like that, and taking care of her for her last 2 years of life. And I'm getting to that age where these things become more important. And as you know, most of you that have been tuning in over the years know that our population that we work with are seniors. So we felt that it's time with our health and wellness and health, safety and wellness program campaign that we're initiating in 2023, we felt that this was a good place to start. So today we invited Absolute Hospice in to let's kind of look at some of the myths. And I want to introduce Miss Emily Wagner, who is a registered nurse and administrator, and Larry Wagner, who is the #1 cheerleader, volunteer, and CEO. Now that you know that's a hell of a title there. Cheerleader, volunteer, and CEO. So you know he's working hard. But these are the two that are the administrators and drum majors for hospice, and what to dispel some of the myths, let you know what services they provide. And we want to get an opening statement from both of you all, but I want to go down this list that's on your website of myths. But just give us an introduction, you first, you second, and then I'm going to read these questions and we're going to discuss the questions. Is that all right? Thank you very much, Ms. Wagner.
Thank you, Mr. White. We really appreciate you allowing us to come and join you today. It's very important to me that people understand hospice. We started this because I was retiring as a home health nurse for almost 30 years. And God said, no, you're not going to retire. We're going to do this. So it's very important to me that the message gets out there, what hospice can do for our people.
Well, right quick though, you were a home health nurse?
Yes, sir.
So you have an extensive background.
Yes.
In home health care.
Yes.
We're going to come back to that.
Okay.
Larry?
Regarding the hospice, Emily and I found each other late in life and newly married in 2015. And Emily went to a conference on hospice and cried the first day, and second day said she wanted to have one, to do this.
Wow, that's talking about, what's that love at first sight?
Yes.
That's really.
Yeah.
Let's kind of make this discussion, you had something else you wanted to, let's make this discussion around the questions. Okay. And that way we can answer some questions that maybe the audience has in their mind, because this list of myths and facts is pretty extensive. So let's see. Hospice is a place, true or false?
False.
What is hospice?
Hospice is
the fact.
The fact. Hospice is a set of services provided whenever the need exists. Usually in the patient's home, about 70% of hospice care takes place where the patient lives. But if the patient were to move, say, to an assisted living, a personal care home, we can follow them there.
Wait, let me ask you this. What you just said.
Yes, sir.
First thing you said, 70% of hospice takes place wherever the patient lives.
Mm-hmm.
So you travel.
Oh, absolutely.
So because you might be in this section, the patient may be in another section of the county or the city.
Correct.
Although we try to have patients be local to us. There are many hospices throughout the Houston area. And of course, if there's something they need that's more urgent, you don't want to have patients that are far away. We may accept some, but we prefer not to if it's going to have too much travel time to get to a nurse if there's a serious problem may develop.
Now you said something. Far away. Kind of explain what you mean. So are the providers that come out to the patient, you're saying you want to have rapid service if they have a need arise, then you can get to them pretty quickly? Is that?
I don't like the word rapid because you know,
Okay.
we have patients who are, I guess, up to 40 or even 50 miles away from us sometimes, and that entails a lot of time to get somewhere if there's an issue or just where a nurse needs to go visit them on a more urgent basis.
Are the providers that's dispatched from your agency, are they all registered nurses or LVNs or?
We have registered nurses. We have one LVN. But there are other people providing services, other disciplines providing services. It's not just nursing.
Wait a minute, what that mean?
It means we have chaplains available, we have a social worker available.
Whoa. So you have multiple services?
Yes, sir. Yes, we do.
Oh, I see.
And
I
that's a
didn't know that.
Medicare. It's a Medicare requirement that you have these services available.
A Medicare requirement.
We are.
So you have to have some credentials
Yes.
from like who?
Medicare. We're credentialed with Medicare, and we're accredited with an accrediting body, which makes us a little bit higher level than just Medicare.
So like a hospital is associated with an accreditation board.
Correct.
And they have to meet certain standards that meet medical standards.
Yes,
And you have to do the same.
absolutely.
Okay, myth number 2. Hospice is only for people with cancer. True or false?
Absolutely false.
Absolutely false.
Absolutely.
So anybody out there
Who was terminal.
who is terminal, that's not the only people you serve. You service everybody.
Correct.
Myth number 3. Hospice is only for old people.
False. There are pediatric hospices.
Well, wait a minute. Say that again.
There are hospices that care for pediatric patients. Very few, but there are. Our agency does not care for pediatric patients, but we can care for up to and including seniors.
Number 4. Hospice is only for dying people.
That's false. The hospice, our chaplains, our social workers can help the families of the terminally ill patient. So hospice is there for the families.
Now it says almost 20% of hospice patients are under the age of 65. That's a pretty good percentage.
That's true. Yes.
Hospice can only help when family members are available to provide care. True or false?
False.
Well, how did that start? Where did that myth develop from?
I don't know. I don't know where the myth developed from, but I'm here to tell you that there are patients that do not have family members. And part of the social work services is to help find people who can help take care of the patients. A lot of the times the patients are fine and just with our care, they're okay.
So the person that's looking at this right now, what comprehensive services do you serve, or is that all hospice?
All hospices are under the same requirements that we are, to provide skilled nursing, a social worker, spiritual services through our chaplains, CNAs, which are aides, hospice aides, to go in the home and help take care of activities of daily living. And also, we have bereavement counselor.
So, for an example, how do you select chaplains?
How do I select chaplains? They apply for the position, and remember, well, this is God's agency, and He helps guide us in the people that we hire.
If I may add, the chaplains are not allowed to be proselytizing for a particular faith or denomination. So it's more spiritual guidance and conversations they may have with the patients or their families.
So if the patient says, I'm Catholic, do you provide a Catholic priest?
No.
Or it doesn't matter, they can't select like that?
No. And a lot of times the families will say that they have their own, but Medicare still requires us to at least have an assessment from a chaplain, because we're supposed to be caring for the whole person.
Yeah, some patients will decide they don't need to have any chaplain service at all, or if they have a relationship with a pastor or a church that they go to, the family may maintain that, and we don't need to do anything else for them in that regard.
So do you find that to be the case largely, or it just depends?
Overall, the patients and families welcome the chaplains.
Okay. So now the social worker, describe what the social worker's standard of care is, or credentials.
Our particular social worker, she is an advanced practice social worker. She has a dictionary in her mind of things that agencies that can help provide provider service.
It's more like she's an encyclopedia
of services. And it's her job. There are many services that people are eligible for. They don't know they're eligible for.
Now, see, you just said something right there. I'm making a comparison. Now, FEMA applications for assistance. Statistically, African Americans are at the bottom of getting the service or the funds, because they don't want to stay on the phone that long. It's too much this and that. It's, oh Lord, I don't even want the rigor that it takes to fill out the paperwork, be on hold, get turned down. At one time, I was a housing inspector contract for FEMA. And a lot of times you would see that people would get a determination, a dollar amount, and they wouldn't contest it. But that was my job, to go out after they filed a complaint to see if that guy before me made a bad assessment and this person should get more money. I'm finding that with anything dealing with applications and process, it seems like we need more information and patience to get that, complete the cycle or complete the task. So the social worker is like calling in the Marines.
Exactly, and especially ours. She is the best.
She knows her stuff. She's really good.
Really, really good. And the woman works tirelessly to help our patients.
Now, we're not talking about a particular Gertha, are we?
Yes, we are.
See, I used her with my mom to help with an assessment, because I'm trying to figure out.
She's amazing.
Right. Very, very, very skillful and caring.
Oh, absolutely.
Yeah, because my mama was tough. She didn't want to do this, she didn't want to do that.
Gertha can handle it all.
Correct. All right, let's see, what's this next one?
May I say one more thing
Oh,
about
yeah.
Gertha? Gertha actually went on an admission with a patient with me, and I'm a registered nurse. She's a social worker, but she was right there with me, helping me. And she's amazing.
Right. Hospice is for people who don't need a high level of care. True or false?
That's false.
What does that mean?
Well, hospice is for someone who needs a high level of care. Our job is to keep people comfortable. That requires skill and everyone being involved. The physician, the nurses, and input from the social worker and the aides. Everyone's important to make the patient comfortable.
So does that include like a dietary recommendation sheet? Do y'all do that? That's not in what you're supposed to do, or is it?
It is.
It is.
All our registered nurses also can help with dietary.
Well, let me ask you this. Like for pharmacists, I'm going to ask you a question and trying to... So at one time, we were trying to get this agency that had a pharmacy in it.
Okay.
And the people that attend the breakfast, right, from different areas and civic clubs, had a question about medicine compatibility. So do you have, like if the hospital and the doctor gives, or the social worker from the hospital gives a recommended nutrition sheet or recommended dietary sheet, do they match or
Everything has to go through the doctor.
everything goes through the doctor?
Yes, we can't do anything without a doctor's order.
So you're saying that a patient of yours that's connected to a hospital or a doctor still has to approve some of the things that you do?
Oh, absolutely.
We have a medical director, and Emily consults with her on a very regular basis for orders and any changes that they want to suggest for the patient. So Emily may come up has the knowledge of what they may need to do next, but she'll verify that with the doctor, and the doctor has to provide orders that goes in her patient's record. So Emily can't just make decisions on her own about what we're going to do next.
So, now this is just a curious question. Do you see more doctors making house calls? Is that something that you even see?
There are organizations where the doctors go out and make house calls. Our doctor does.
So when you say organizations, you mean like medical organizations?
Yeah, there's groups of doctors that, and I don't know what they're called, but they all have their own company names.
See, what I'm trying to open up is all of the conversation that we can get on healthcare.
Yes, sir.
We have a session coming up where we're going to have some Medicare navigators explain what we thought we might have known about other benefits that's available that we're not making use of. See, that's part of the missing link is information.
Right.
And that's why we want to have as many of these sessions as possible where you can educate, and because it's all kinds of, I want to tell you this. Now, some people say that I will cuss them out. They ain't never heard me curse.
Well, if they push you far enough, it may be necessary.
Well, yeah, it might be, but not yet. But I'm just saying that's a myth. But people, I don't know how I got the reputation. And I'm talking about when I do public speaking, I'm talking about, I said, man, you don't want to get that guy riled up, because if he get riled up, he gonna cuss you out or whatever they say. But So here we have all these myths.
Yes, sir.
We don't know where they started. That's like I don't know where it came from. I don't know where it started, how it started. But people have that in their mind.
Yes.
Well, there was the movie Philadelphia, I think, in the 80s perhaps it came out, and there was about a lawyer or some person who had AIDS. And that person was spending part of the time in hospice care. Yes.
Yeah.
And so there are hospices with inpatients. Well, we don't have an inpatient facility for hospice patients.
So what is the norm? Is the majority of hospice on location, or is it at home?
It's at home.
At home.
People want to be at home.
Yeah, people want to be at home.
They want to be in their homes.
They were born at the house at one time.
Right? And that's
Fair
where they
enough.
want to stay.
If you can listen to music you want to and as loud as you want or whatever, and no one can tell you to turn it off because you're dying,
Well,
you should be able to do that.
Now-
If you want to smell chocolate chip cookies, you should be able to do that.
that's correct.
You can't do that in a hospital.
Now, here's another thing about the hospital. What have y'all heard about this? It's a syndrome called sundowners.
Mm-hmm.
Have you heard about that one?
Mm-hmm.
That happens more at the hospital. Have you heard that?
I have not heard that.
Yeah. It say people get disoriented.
This is true.
Oh, that's true.
That is true.
Okay, because my mama used to get it disoriented when we would have to take her to the hospital. When she got there, it just seemed like she was just different.
And that's why it's good to keep people in their homes.
She want to be what? That's okay. All right. Let's see, what's the next one? Hospice is only for people who can accept death.
That's definitely false.
Yeah, that seems like that's a contradiction. I mean,
Our hospice staff is able to speak with people and help them, but let's face it, none of us is, like my husband likes to say, none of us are getting out of here alive. And so,
that's true.
Our hospice staff, that's what they're trained to do, to help people get through this.
And we hope to have people have a relaxed, pain-free departure.
Well, I'm trying to remember who it was, but made a comment about somebody was receiving hospice care and got better.
That
Yes,
can happen from time
That
to time.
can happen. And I have my own theory, but
What's your theory?
because people are able to have the medications that they need, they're comfortable, they can eat. Sometimes people can't afford medication. Sometimes they can't, they have to make a decision between medication and food.
Now let's talk about that part. Because this next question is going to touch on that as well. So,
With the Medicare hospice benefit, we're required to provide the pharmaceuticals to ease the patient's pain. We don't do curative medicine because they're on hospice because there is no cure for what they have. But if they need pain medications, we can have more advanced pain medications available to them at hospice cost.
so if you're on hospice care, does that mean you don't take blood pressure medicine anymore?
No, sir.
You still take blood
You
pressure
can
medicine?
still take the medications that have been prescribed for you.
But if you don't have the money, that's where the deficit comes in. So this is the next question. Ties into the next myth. Hospice care is expensive.
It's absolutely not expensive.
So what's
you.
the financial component that ties into Medicare or Medicaid? Or does Medicaid get involved?
Oh, yes, sir, absolutely. And we are Medicaid accredited also. That wasn't the right, but we can take Medicaid patients. But Medicare provides a daily stipend for us to provide all our services, which includes the nursing, the social worker, the chaplains, the aides, the bereavement counselor, dignity supplies, medications related to the illness, durable medical equipment. Some people, you know, they don't have a bed to sleep in, which is true, but we provide the hospital bed, that type of equipment.
So that's the financial link with Medicaid or Medicare.
Both.
Medicare.
Medicare and Medicaid.
Yes, they provide those things for the patient. Medicare did an excellent job when they developed the hospice benefit. They did. And so when we say sometimes our people get better, because some people don't have anyone, and they have all the attention from our staff.
Oh, that's a
Plus-
good point.
Yes,
Some people don't have anyone.
and they don't. They don't have anyone.
Now, if you're in a lot of pain, it could be all of your physical energy is going to trying to block pain. And in that situation, you might not be able to try to help yourself heal from something. So they can get better if those pain medications allow them to be able to relax, and their immune system may then get a boost.
And this brings in our social worker again, because say they're having difficulty meeting their bills, she can help intervene. She's going to do what she can to make things easier.
Well, since you said that, what has happened? How did COVID-19 impact what you do?
For us, well, like I said, the volunteers, a lot of patients didn't want staff in their home because they were afraid we were bringing it. And I did patients in the wintertime out on porches because they didn't want us to come into the home. So it did impact the business.
So what do you see as the future going forward with COVID and hospice? Do you see it turning the corner, going people being more comfortable, or what?
Yes, I think so.
Well, COVID seems like it's becoming less severe for most people. In which case, people are a little more relaxed about it. They're not as concerned. At first, when 5% of patients who got COVID died, that was, I'm sorry, I don't want you visiting my house. I don't know where you've been, who you've been around. And the most severe COVID seems to be dissipated and gone now. So it seems to be a less severe disease.
So,
I've had it 3 times, so has Emily.
wow, y'all walking miracles, huh?
Perhaps. Some people don't get any symptoms at all, but they may spread it around. We had to stay home. We definitely had symptoms. We had to manage.
Okay, let's go over this 9 and 10. Hospice is not covered by managed care. We just answered that, right? Or is that managed care we were talking about?
No, managed care right now, managed care, if you have managed care, you go back to your old Medicare benefits and Medicare pays us. So.
Oh, managed care, I know what you mean now.
Yes,
Okay.
the Medicare managed.
So what do they do?
If you are on an Advantage plan right now, because they're fixing to change it in the future, but right now, if you're on a managed plan like Kelsey-Seybold, I don't know, Texan Plus.
Texan, so that's what you mean when you say
Yes.
managed care.
Yes.
Okay.
If you're on an Advantage plan, you
Advantage.
revert to your original Medicare.
Okay.
So it makes you eligible.
It makes you eligible.
Yes.
Hospice is for when there is no hope.
That's absolutely false because we're there to bring hope.
Good point. Now you have other services that you provide that's on your website, right?
Yeah, it's on the website. The services that is within the scope of the hospice benefit, the nursing, the social work.
The things you mentioned
Yes.
earlier.
Yes.
Give us a closing remark from you as it relates to essential knowledge. People don't know anything. They just turn the TV on and bam, what would you have them to know?
Well, we have a number of different pages on our website that are, I'm information junkie sometimes, so rather than having them call the hospice or Emily at all times of the night, common information that she shouldn't have to answer herself, we've tried to put a lot of that on the website so that they can get answers to questions. We suggest, I've got about 20 questions on the website. Ask your potential hospice provider, do you offer this? Do you provide this? Do you provide this? If they're saying no, those are things you should be eligible to have. So we suggest,
Good point.
call a different hospice. If you call us, you're mostly going to hear yes, 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 and yes. So we may want to have us do the service for them.
Yes, ma'am.
From my heart, yes, I would love to have a patient come to us. But if you choose not to come to us, do not overlook the benefit. The benefit is amazing.
People need to know the benefit of hospice, period.
Exactly.
That is because we just don't know.
Exactly.
And it's always somebody in the family that might have a little knowledge, but just general knowledge. And what I'm saying and what Charity Productions is doing, look, we're trying to put as much information before you right now as soon as, because you need to know. You need to know about mitigating threats outside your house, in your neighborhood, and with yourself.
You mentioned the problem of going to FEMA, and to help keep people from having to go to the Medicare website and trying to find out everything that they might be able to have as part of their hospice service. We've tried to list all that so that they don't have to go to the Medicare website and spend days trying to find it.
Because that's normally more complicated than just going to, like what you're saying, your website or somebody's website that has the answer to the question. Alternative types of searches, you can narrow it down and get to what you were just specifically trying to find out at this time. Well, we want to thank you for coming in. And look, we probably have to do this again and extend it a little bit. Of course, some of the professors, I mentioned that same thing to them because we just got into it and it's so dynamic that you just can't do it all in one setting. So just look for me to call again when we get to this, because in 2023, and you'll probably be at the breakfast on the 20th, right?
Absolutely.
Okay.
Yes.
And we're going to do this kickoff and for 2023. But we want to say that we want to thank you, both of you, for coming today and giving us this information on hospice. And you do have a website from Absolute Hospice that you can go to and get information that you would probably have to be on there a long time searching Medicare site. And I want to make sure that I invite you all out when we have the Medicare navigators, because we're going to convene people and let people talk to them, ask them questions about enrollment, pre-enrollment, and all the things that they want to have, and we want to knock out all the myths. So we're going to have a series of those Medicare navigators to help answer questions that people thought they knew, but the benefits changed, or they were upgraded, or they were removed. Whatever happened, it's a change, and we need to always be upgrading our information and outreach for service. So we're going to sign off today. This is Charles X. White with Community Views and Solutions. We're looking forward to you for our next segment. We'll let you know. We'll see you next time, and stay safe.